Plasmalyte as much just yet. All right, so pH-guided resuscitation. So as we mentioned on the first slide, that when you have a pH, you basically have three choices. You can give LR, all right, just to maintain, right, or Plasmalyte. You can give, you can alkalinize the blood, so you want to make the pH rise, right? So the pH is 7.05, you want to make it 7.15 or 7.25, 7.35 normalized, right? And that's where you give a bicarb infusion to raise someone's pH, right? If you want to lower someone's pH, you want to cause hyperchloremic metabolic acidosis, well, great, I got a solution right for you. That is called normal saline, right? So if someone's pH is more than 7.45, perfect, normal saline, it's their time to shine. Here it is, right? You're up, champ, right? That's when it would be great to use normal saline. Okay, so we'll talk more about these in detail. And fluid should be viewed as a drug. Oftentimes, when someone comes to the emergency room, they get 3 liters of normal saline. That's like their welcome present, right? They get that, and they get a UA, a chest X-ray, and a 12 lead EKG, right? So that is their welcome present. So unfortunately, we have to make the decision at the ER. So we got to convince them if we can, but it's a one-time opportunity to fix someone's pH, right? And he's like, well, I don't have an ABG, but you do have chemistries usually, right? Oftentimes, if you don't have that because they might be super sick, we have, we can assess, they look super septic, right? Well, it's probably going to be beneficial to give like a bicarb infusion or LR. LR is not going to make someone's acidosis worse, but it's okay to use. So LR really should be kind of our default solution. If we can get bicarb in there for someone super acidotic, that's great as well. Okay, so large volumes of fluid will definitely change the pH. And so we want to be making good choices, right? So do we want to use abnormal saline or like lactated ringers, right? If we have 2 on the shelf, which one should we grab? Okay, someone has metabolic alkalosis, there we go, that's normal saline, right? That's the one that we want to be giving, okay? Sometimes people have respiratory acidosis and their bicarb is like 35, 40, and giving normal saline to those patients is not going to fix that bicarb. That bicarb wasn't causing alkalosis. That bicarb was neutralizing the high CO2 that was retaining from our CO2 retainers, right? So you just got to be careful. Like, oh, they got alkalosis. Don't just treat a number. We have to look at the whole ABG interpretation. Okay, so there are rare causes of a metabolic alkalosis. So someone, down some baking soda. Someone has, and so. They down some baking soda, they got down some antacids. There's gastric losses, especially if we start losing some GI content, some hydrochloric acid from our GI tract, right, from our stomach. Getting rid of the hydrochloric acid is going to tip the scales in favor of bicarb. Therefore, we're going to get more alkalotic. In that case, they're losing a lot of volume, they're hypovolemic, and their metabolic alkalosis. Oh joy, there it is, their normal saline. That's your perfect time to come in and restore volume because isotonic, and also to correct someone's metabolic alkalosis. Some things that we do, especially in the ICU, is we induce alkalosis with a contraction alkalosis. And we'll talk about this more when we talk about diuretics, but these guys, we give potassium wasting diuretics, all the K is being lost. You can just think of K loss being hypokalemia. Hypokalemia is alkalosis. You can think of that. But truly what's happening is you're losing volume and you're making the bicarb more concentrated. Therefore, it's called a contraction alkalosis. And sometimes you overdo with diuretics and you look at the I's and O's and the balance is like -4 liters. Like, oh, joy. They're breathing great right now, but they're hypovolemic, right? So how do we fix that? Well, it's your time to shine, right? Normal saline, that's where it's at, right? That's going to acidify the blood and it's going to restore volume. But if they still need diuretics and they are still fluid overload, they're positive 3 liters, then giving normal saline is not going to be the option. What's the option then? We can give a diuretic that's going to acidify the blood, right? Or a K-sparing diuretic. One of the two will help us out, right? And usually we give like acetazolamide, which inhibits carbonic anhydrase. Therefore, we stop making bicarb, right? CO2 in water starts building up, and carbonic anhydrase inhibitors such as acetazolamide. Okay, we'll talk about this more in detail. All right, someone has metabolic acidosis due to kidney failure, right? They have an AKI, CKD, and they need fluids, right? So that's where we would give bicarb drip, right? So they're acidotic and they need fluids, right? Might be some pre-renal failure with some acidosis that's developing because of acute kidney injury, because of hyperkalemia might be happening, or acidosis may be occurring with chronic kidney disease. that's where isotonic bicarb is our go-to agent. So there's such thing as hypertonic bicarb and isotonic bicarb. So hypertonic bicarb is your bicarb push that's on the crash cart, right? Is it concentrated? You bet. It's 8.4% bicarb and 50 mLs of normal saline, right? And it is, I think it's pretty sure it's normal saline, but then it is like a milliosmol of 2,000, right? 3% saline is about 874, right? So it's like literally 2.5 times the concentration of 3% saline that we always like, oh, you got to get citrulline for 3% saline, right? And it is extremely concentrated. Okay, so it actually sometimes like might help in certain situations, like a cardiac arrest patient that has overdosed on like the tricyclic antidepressants and someone that's overdosed on lidocaine maybe. But other than that, there's not great reasons to give bicarb push. I should say, and then the caveat would be someone that has severe hyponatremia, because you give 2 of these guys, that's going to raise your it's like 6% sodium chloride IV push, right? So really the only 2 indications are rarely if someone overdoses on their depressive meds, antidepressants, or if someone has a cerebral edema of some sort, right? Really high ICP or really low sodium. Then a sodium bicarb push, beautiful, right? It's going to raise the sodium by like 2 to 3 points, right? And that's going to then, hopefully pull some fluid and help someone who is in a crisis neurologically. Okay, so that's bicarb push. And then we have isotonic bicarb drip. So bicarb drip is D5 water, right? If we mix this 3 amps of bicarb, that's a normal saline, inside of normal saline, that is extremely hypertonic, right? That shouldn't even be an option. Unfortunately, it is an option on a computer. I've talked to pharmacists like, when would this even happen? When would you want to give that much sodium, right? It's like the osmolarity would be like 600, right? Instead of the osmolarity of normal saline at 308, right? It's extremely hypertonic. So giving 3 amps of bicarb into a hypotonic solution, such as D5 water, that is going to make that isotonic. Someone did the math and they said 3 amps is what you want, right? If you give 2 amps, it's way too hypotonic. You can't get, that's under what we need. So we want to give isotonic bicarb, or whenever someone says bicarb drip, that's what they mean. Okay? So bicarb drip is given with someone that needs that has an AKI and has a fluid deficit, right? And they found in research that it prevents dialysis. So it's indicated for someone to stop dialysis, right? Those who got it didn't get as much dialysis as those that did not get it. Okay, and then NAGMA. So we'll talk about all the different kinds of anion gap situations where they have a high anion gap or a normal anion gap. But we have metabolic acidosis. Give metabolic acidosis, give something that's going to fix the acidosis. Which one of these fluids fixes the acidosis? Bicarb, right? So bicarb is going to be our option there, right? And not a push. It's going to be a worse option, as we'll show. All right, so bicarb drip, when is it needed? You got metabolic acidosis, right? I should say not, this is kind of with a grain of salt. Other NAGMAs is actually beneficial for that, right? So that's okay to give for non-anion gap metabolic acidosis. Any kind of metabolic acidosis, give bicarb drip, right? LR is not harmful, right? So it's not harmful, but it's not better. So it's better to give bicarb drip. All right, so fix the underlying cause of metabolic acidosis. Well, that's what bicarb drip will do. It will fix a low pH. It will fix a low bicarb, right? And we'll find out when you have NAGMAs or non-anion gap metabolic acidoses, that's because you have lost bicarb somehow. Either you pooped it out or you utilized it completely because you're producing acids slowly. So that might be a reason why we're using all of our bicarb, right? Another reason why you might neutralize bicarb is with acids, right? So we're building up acids here, like lactic acidosis would be a good reason. There we go. All right, so we have lactic acidosis, right? Bicarb is not going to fix the underlying problem. It will neutralize the pH a little bit. Really, the job when we have a elevated lactate is to fix the underlying cause, right? Someone has cardiogenic shock, fix the cardiogenic shock. Someone has septic shock, fix the septic shock, right? So treat the hypoxia or treat the low perfusion. That will fix lactic acid. The bicarb drip is just a band-aid, if anything. All right, someone has ketoacidosis. Yeah, it will help a really low pH, but the goal is to fix the ketoacidosis, right? 2 out of 3 of the ketones are acids, and those get made with lipid breakdown with the absence of insulin. So insulin is really our priority in those situations. Bicarb drip's great, and LR is not going to harm them. Normal saline, though, in DK, that's going to make someone even worse acidotic-wise, and also make their the potassium go up, and also cause a higher incidence of acute kidney injury. All right, someone has hyperchloremic metabolic acidosis. Well, I probably should not give normal saline because that's what it causes, right? So bicarb drip can help hasten that recovery if someone has a NAGMA of some sort. Okay, so examples as we mentioned. So we have isotonic bicarb versus hypertonic bicarb. Isotonic bicarb is where we have 1 liter D5 water. Right there, we're mixing 3 amps in the bag, right? We can mix it in a pinch out of the crash cart, right? There's usually 3 amps of bicarb and a bag of D5 water in there that we can mix, okay? Someone is very, very hypovolemic, right? They've been vomiting for the last 24 hours, and you realize that they're probably going to benefit from isotonic bicarb infusion, okay? All right, so you must be cautious about fluid overload still, right? It's isotonic, right? It's going to raise intravascular volume. As we'll come to find out, it's not that much, right? Usually every volume you give usually leaks about 82% of the time, right? So it's not the best thing, but it will restore volume, that little 28% or 18%, right? And then bicarb push, as we mentioned, is only used when they're really, really concerned about fluid overload. You want to raise someone's bicarb, right? And then, of course, you give it super slow, like over 10 minutes if you needed to, all right? And it can raise sodium significantly, about 1 MEQ for every amp of bicarb, right? So 1 MEQ, so if you're giving 2 amps, it raises about 2 to 3 points of sodium. So if someone's sodium is 112 and they're seizing, it's going to raise their sodium to 115, and it's going to hopefully fix their seizing situation. Okay, so hypertonic bicarb is only short-lived, so it's not recommended to be given this over and over and over again, Q4 hours or Q2 hours. Okay, you also have to be breathing to give bicarb push, right? Because what does bicarb do? You provide all this bicarb to a patient. What's going to happen? They're going to convert that because they have carbonic anhydrase, and all the RBCs and all the cytosols of the body and the proximal convoluted tubule of the nephron has carbonic anhydrase, and it's going to convert the excess bicarb into CO2 and water. If you convert all that CO2 and water in that your tissues are making, right, into all that bicarb into CO2 and water at your tissues, and you try and circulate to the lungs, and the lungs are like, hey, I'm ready to blow off CO2, and the lungs are like, I'm not breathing, I'm dead, I'm cardiac arrest right now, I don't know what to tell you, you got to resuscitate me first, and then I'll start breathing, right? And then we're taught in ACLS to breathe how often? 6 to 8 breaths per, about six breaths per minute, right? 10 breaths per minute for every 6 seconds. So 10 breaths a minute is not going to get rid of enough CO2, and that's going to build up and worsen someone's acidosis, lower someone's pH more if you give bicarb pushes, if someone's not breathing. Okay, so the drip over here versus the push, right? So here's our drip right here is isotonic, and our push is very, very hypertonic. You see it's 2,000 milliosmoles. That's going to rip through some veins very, very easily. It's very, very vesicant-like. Okay, so isotonic bicarb will lower your potassium. So if you're giving bicarb drip, you got to be alert that you should be checking potassium, because that will start falling with bicarb infusions. Right? It's great at fixing hyperkalemia. It's great at fixing someone's acidosis, but it's also great at causing hypokalemia. Right? Does bicarb push lower potassium? Nope, does not, right? So that's why bicarb drip is not part of hyperkalemia cocktails anymore, okay? And we'll explain why that is. All right, so hyperkalemia, perfect for bicarb infusion, not for bicarb drip, right? Someone has emergent hyponatremia, that's perfect for bicarb push, okay? Cerebral edema, etc. Okay, and if you give bicarb drip, 1 liter, that's 1 liter, and that can raise someone's volume, so you have risk of hypervolemia with a bicarb infusion. So hypertonic IV push bicarb. All right, so what is its effect on potassium? Because oftentimes it's part of cocktails for high potassium, so we'll give it to hopefully lower their potassium, but as we're going to find out, it's extremely, extremely hypertonic. We said 2,000 milliosmoles, whereas like a regular glucose D50, which is very, very osmotic, right? That's about 1,200, right? So it's extremely osmotic. So what does it do when you give bicarb? it's going to pull all of the potassium and other solutes out of the cells into the vasculature. So I thought we wanted to lower someone's potassium. How is pulling potassium into the serum going to fix someone's elevated potassium? Okay, every amp will raise your fluid volume because it pulls all that sodium, and it's going to pull a lot of, and it's very, very hyperosmolar. It's going to pull a lot of water into the vascular space. So about 250 ml. So you want to give a 250 bolus to someone super quick? Yeah, IV push bicarb will do it. Okay, and we know it's also extremely irritating to the vessels, and you can see how it's pulling all that stuff through and causing a lot of damage to the vessels in the first place, right? So central line is preferred for these patients, right? And bicarb, yes, bicarb increases pH, but you just pull potassium out of the cells into the vasculature, which is going to exchange and with hydrogen, and that's going to cause an acidosis. So you cause an alkalosis and acidosis. So what won? Nothing. So nothing changed. All right. So it's not beneficial to give a bicarb push if someone is acidotic. Is the key take-home statement, right? So if you give a bicarb infusion, an isotonic bicarb drip, that will nice and slowly lower bring the pH back to where it needs to be, and it will, yes, lower the potassium as well. It will also dilute the potassium because there's no potassium inside a bicarb drip. So that's going to add 1 liter of stuff to a potassium concentrated human, right? So giving isotonic bicarb will lower the potassium. An IV push bicarb will do what to the potassium? It will raise it transiently, and it will go back right back into the cells in exchange for hydrogen. Okay, so if you have someone that's hyperkalemic, that's where you would want to use a bicarb drip. Okay, so I'll get rid of this piece right here. All right, so then you got CO2 effects. We talked about the effect of bicarb push on CO2. Right, you give bicarb push to someone. All this bicarb is being given and given and given, and you're going to do what with it? You're going to give all this bicarb, get IV push bicarb, and you're going to start say, I got way too much bicarb. So your cells are going to start converting that bicarb into CO2 and water. And then hopefully you're going to exhale that at the lungs, right? But if you're not breathing, that's going to, no respiratory rate, or it's a low respiratory rate, like at ACLS rates of 10 breaths per minute. That will then cause a dramatic lowering of pH because you're building up this carbonic acid, and that will lead to further arrest, right? So it's not beneficial to give in cardiac arrest for that reason. Okay, and just giving bicarb, just 1 amp of bicarb has about 100 millimeters mercury of CO2 in it, right? And you're going to just diluting that into the serum of someone that already might not be breathing for a second, right? So their CO2 is probably climbing in the first place. So that's not going to be beneficial for someone that has that's apneic, a presented apneic. Okay, so pushes of bicarb will raise someone's CO2 levels. Okay, if someone is breathing, you can increase the respiratory rate on the ventilator, and yes, you can blow off the CO2, right? But if they are not breathing, they're in cardiac arrest, right? That won't help, right? You can't exhale when you are dead, when you are cardiac arrest. Okay, and then what else? So if you do have to give bicarb push, if someone is on a ventilator, that's where we would then give it a slow IV push, right? That would then be that would kind of slowly let us blow off the CO2 with the ventilator. Okay. If you're giving bicarb drip, usually you have to give it via its own little IV because it's not compatible with anything, unfortunately. It's very, very alkaline, of course, and it needs to be on its own channel, right? You have to be, or it's on its own channel, but its own IV. Okay, so it's not mixed with normal saline, otherwise that's going to make a very, very hypertonic solution, right? It's 3 amps in D5 water. If you do 2 amps, it's too hypotonic, right? It can be run at fast rates to restore someone's volume if they are also hypovolemic. All right. So summary: do not give this for hyperkalemia. Bicarb push for hyperkalemia. What can you give for hyperkalemia? You can give a bicarb infusion, an isotonic bicarb drip. Okay. So when it's HAGMA or NAGMA, that's great for bicarb drip. For bicarb push, it's going to worsen the situation. Okay. So give slow if you have to. All right, and in cardiac arrest, it's only if they overdosed on a TCA, a tricyclic antidepressant, or overdosed on like lidocaine, for instance. That would be an appropriate reason to give a bicarb push if someone's in cardiac arrest. That will, saturate the channels and hopefully get the channels back up and running again. So if someone had overdosed on those agents, right? Otherwise, a good reason for bicarb push is someone that is seizing, that's hyponatremic, or someone that is neuro, right? A neuro ICP situation. Okay, and then pH less than 7.1, they're like, you know what, YOLO. The pH is 6.7. Might as well try it. Let's see if it works. But as you kind of find out up top, it's not going to, if you're not breathing, it's not going to help the situation, right? Also, they did lab studies and they found that it doesn't change the pH because it pulls so much potassium into the serum, and then that then goes back into the cells, right, in exchange for hydrogen. Right, so that's a problem that happens with bicarb push, is it doesn't actually change the pH any. Okay, so that's the idea with with bicarb pushes or hypertonic bicarb infusions.